The radioactive iodine is then often given after surgery for really two purposes. The first purpose is actually to ablate any thyroid tissue that might be remaining after a surgery. And that's because later on you want to use radioactive iodine to detect any recurrences. So it can be used initially for that, but then there's also diagnostically, do we actually see any areas of possible cancer outside of the surgical bed? So we can use radioactive iodine to detect metastasis in bone or perhaps metastasis in the lungs that may have gotten away, or even recurrences in the neck. So, and then the new phrase for this is called theranostic, I guess. In other words, it's both therapeutic and diagnostic, where you give an over 100 millicurie dose, and at the same time that you're detecting where the cancer might be, because it's radioactive and really selectively taken up by these thyroid cancer cells, then they are obliterated, they can die. So initially it's, to get rid of the remnant of the thyroid. It's also used to diagnose, and then it's also used to treat. So in the beginning, all patients will usually who have differentiated thyroid cancer, will get a dose of, usually a therapeutic dose, and we'll be able to evaluate all of those things. And then the hope is that, we won't really actually have any recurrences, but that doesn't always happen. So sometimes we'll see thyroglobulin levels, which we then monitor after that, and ultrasounds monitoring the neck. And we'll follow along, and after maybe a year or 2 years, if it starts to increase again, they may actually get another dose of iodine, radioactive iodine, in order to treat these recurrences. And radioactive iodine really, really works the best when the cells are caught at a very early stage. Sometimes small enough that only the iodine scan can see them. Sometimes we can't even see them on an ultrasound or actually on a CT scan. So that's actually when radioactive iodine works the best, is when the number of cells are the lowest. And then it's given usually a few times, up to a few times. Hopefully they'll be cured after one dose. But if they do have recurrences, it will be used as long as it's felt that there's a clinical benefit. So if you give somebody radioactive iodine and then the thyroglobulin shoots up again within 3 months, then it really hasn't worked. And that tells you that even if there's cells that are taking up iodine, in other words, on the scan you can still see some cells, it suggests actually that there's cells that are not taking up radioactive iodine. And because now we have the ability to treat these with now systemic therapies, we are more and more trying to get physicians to order a CAT scan after every iodine treatment. And the reason for that is that the radioactive iodine will actually detect the cells that take up the iodine. Well, that's wonderful, and these are the ones that are actively treated. But sometimes there are cells right next to them or nodules altogether separate that are growing and they're not taking up iodine at all. And unless you actually do a CAT scan, you won't be able to see that. So you need somehow to get that imaging. Unfortunately, sometimes the CAT scan that sometimes they'll use a PET scan also, because when iodine is not being taken up, they'll also use a PET scan. But you want to do some sort of imaging right after the radioactive iodine to make sure that every spot you see on the CAT scan is being taken up by the iodine. And so as long as that's happening, you have clinical benefit. At a certain point, and we know actually after approximately 600 millicuries, 700 in that range, you're very unlikely to actually cure a patient. So at that point, unless you really have gotten a good 2-year interval or something with radioactive iodine, you would then start to hold back and not use that modality anymore. But it's really meant first to cure any microscopic metastasis and then maybe to control some recurrences.